Hi, I'm the current fellow at the University of Chicago in orthopedic oncology. I did my medical school and residency at UAB in Birmingham, Alabama, and I'll return there as faculty in adult and pediatric orthopedic oncology in September of 2024. I hope that this is an efficient review for you to get you going as you prep for a rotation. I'll try to give you a basic foundation to build on. Thanks to my mentors in orthopedic oncology from residency, Dr. Lee Skivchinsky and Herrick Siegel, and in fellowship, Drs. Terrence Peabody, Rex Hayden, Tessa Ballage, Sam Murtar, and Alan Blank. Thanks as well to Dr. Adam Levin from Johns Hopkins for his edits. I do plan to make additional orthopedic oncology education videos, and I'll post them to this YouTube page listed. My email is listed. If you have any feedback or questions, please let me know. I want to continue to refine this content to make it the best it can possibly be. And thanks to Ortho Access for helping develop some wonderful tailored content for MS34 education. Here's an outline of what we'll cover in this video. Additional learning resources are sprinkled throughout the slides with some more listed at the end, as this talk is relatively quick and not fully comprehensive. The intro to orthopedic oncology. When you're on the rotation, I highly recommend you kind of think of everything within three big boxes. So primary bone tumors, whether those are benign or malignant, which we would call bone sarcoma, primary soft tissue tumors, such as benign soft tissue masses, or when they're malignant, soft tissue sarcomas. And then the third box is really metastatic bone disease, and sprinkled in with that is kind of lymphoma, multiple myeloma, other metabolic conditions. But in general, what you should know is that sarcomas are very rare. You're going to see a lot more benign stuff, and you're going to see a lot more metastatic disease than you are going to see primary bone and soft tissue sarcomas. I think you might see sprinkled in with the oncology practice is other things such as joints, trauma, spine, peds, because orthopedic oncology in general is combined with something else just because the orthopedic oncology conditions are pretty rare. You'll also see a wide variety of patients in clinic, all age ranges, and sometimes you'll be providing just a simple follow-up visit or reassurance. And sometimes you're also in the same clinic, you could be giving a patient a new diagnosis of cancer. From a surgical standpoint, you may do something small like a lipoma, all the way up to a hemipelvectomy or resecting the entire distal femur and doing a large reconstruction. The other thing you should know is that the specialty in general is multidisciplinary. We work with a lot of other specialists such as medical oncology, radiation oncology, and plastic surgery. We do a lot of combo cases where we'll work with other services as well in the operating room. So as you're in clinic reading about patients, you may find yourself drawn to reading notes from the other services to gain further perspective on the care within the team structure. As you're preparing for your orthopedic oncology rotation, one of the challenges is going to be the relevant anatomy. Unlike other subspecialties, it's not very focused in the sense that orthopedic oncologists really operate all over the body. In fact, orthopedic oncologists often are operating outside of normal internervous or intermuscular planes. Sometimes the approaches are essentially made up, or when we're doing a wide resection, you never actually see the tumor and we work through the muscle. One of the benefits of this is that you're going to see a lot of anatomy from a totally different angle. The big open surgeries that we do will show you a different look at different structures in the human body that you didn't see from different angles. And that can really help connect the dots for you as part of your education, how you continue to grow your anatomy knowledge. Because really, within orthopedic surgery, most of what we do is musculoskeletal anatomy. So there's a couple of resources listed here I highly recommend you check out. Any three-dimensional anatomy tool is going to be great for helping you prepare specifically for cases as they come up. And then if you need some help learning the cross-sectional imaging and how to look at the cross-sectional imaging, such as CT or MRI, in preparing for a case, EMIOS or e-anatomy is a good tool for helping learn to correlate the imaging with what you see in the OR. And then after you do a case, try to look at the imaging again and really try to correlate what you saw in the OR with what you saw on the imaging. That is really what will help you grow in your understanding of orthopedic surgery and anatomy. Some high yield anatomy that you should review, though, is the anatomy of the thigh and the leg. And that's just because bone and soft tissue sarcomas are more commonly seen in the lower extremity than the upper extremity. And they're a lot less common seen in the hand, foot, and ankle, or even in the pelvis. So the real high yield structure is to know the cross-sectional anatomy of the thigh and the leg. So know the different compartments, know the relevant neurovascular structures. For instance, knowing the course of the common femoral artery, profunda and superficial femoral artery branches within the thigh, how it's covered in general by the sartorius and the anterior compartment is going to be helpful. This is another example showing that the high yield anatomy is going to be the anterior and posterior compartments of the thigh, knowing that in the posterior compartment, you need to really be able to trace out where the sciatic nerve is. It generally is going to live between biceps femoris long head and the semitendinosus. And then if you're working up around the hip, as you did with reviewing a posterior total hip approach, you want to know the relationship of the external rotators in their order as you work from proximal to distal. One high yield point that comes up is that the sciatic nerve generally sits deep to the piriformis, but superficial to the short external rotators. So if you're accessing the hip joint and capsule itself, if the short external rotator muscles are reflected, this will protect the sciatic nerve. A big part of orthopedic oncology is looking at cross-sectional imaging, particularly MRIs. When we're talking about soft tissue masses, MRI is going to be essential for working up and pre-op planning any sort of soft tissue sarcoma resection. In general, the axial T1 image is going to be your go-to. It shows the best anatomy. On an axial T1, fat is white, bright, it's hyperintense skeletal muscle, whereas T2 for H2O, water is going to be bright. So here's just an example image of the mid portion of the thigh showing a cross-sectional anatomy with an axial T1 image. This is going to be really high yield if you can just remember this slide and study this. For example, say there's a soft tissue sarcoma in the anterior thigh, it's going to displace these muscles and it's going to make it harder to see everything because sarcomas grow from inward to outward and they displace structures. Fascia is a good barrier to tumor spread. And so as they grow, they'll push the muscle and they'll push the fascia out of the way, as opposed to they typically will not invade the fascia. So if you know the normal anatomy, then you can really kind of follow along in what's going on in the surgery. So for example, recognize the 4 different quadriceps muscles in the anterior compartment. So here's the intermuscular septum. This is all anterior compartment. This is femur. The bone marrow has fat in it. So the inner part of the bone is going to be white, whereas the cortices are really a dark black, hypointense. And you can see the subcutaneous fat is also white. So you've got rectus femoris, deep to that is vastus intermedius, vastus medialis is the medial muscle, and then the vastus lateralis is this really large lateral muscle you see. When you're looking at the posterior compartment, high yield structures, the sciatic nerve is going to lie between the biceps femoris long head and the semitendinosus. Semimembranosus is more medial, and then you've got your adductors in the medial compartment. The femoral artery and vein are protected by the sartorius. So as you scroll up and down an axial T1 image, you can follow those structures and recognize immediately where they are in relation to sartorius. The saphenous vein is going to be more superficial, and the gracilis muscle will be a little more posterior to the sartorius muscle. Okay, so these are the most common seen conditions in clinic and basic treatment algorithms I think you need to know to survive clinic and understand why a patient is going to the OR for certain conditions. I'll attempt to just hit the high points for each of these. I can't talk about everything listed here for the sake of time, but the slides can be used independently for your review. If you know what is in these slides, you should have a framework and a foundation to build off, and you can supplement your reading and preparation based on the specific things you see in the clinic or the OR. So brace yourselves, it's a lot in a short amount of time. We're going to start with metastatic disease because it is more common. Metastatic bone disease. So in general, when you see a patient with a lytic or radiolucent lesion on an X-ray and they're older than 40 years, you should be thinking metastatic disease. A common saying that we'll use and try to reinforce with you on a rotation is Mets, myeloma, lymphoma. That's your differential for a patient over the age of 40 with a unknown skeletal lesion. How do you work up a patient like that? So if this is the first time this patient's seen in clinic, they have no history of cancer, no known diagnosis, you're going to do an H&P, a CT chest abdomen pelvis with contrast, a bone scan, and some basic lab work with a focus on ruling out multiple myeloma with an SPEP or UPEP. Based on a landmark study published in 1993, we know that a lot of primary cancers will be diagnosed with this workup. If you don't have a diagnosis at that point, you can proceed with a needle biopsy of the lesion. So the TT chest abdomen pelvis looks for the common sites of disease that metastasize to bones, such as breast, lung, thyroid, kidney, and prostate, or BLT with a kosher pickle. This is something you typically learn on other lectures in med school, so I won't harp on it too much, but it's important to keep this in your mind for sure as you're on an orthopedic oncology rotation. The bone scan also looks for other sites of skeletal disease. Certainly in your history, you're going to want to ask about pain in the other extremities, as they may be presenting with one abnormal X-ray, but might need to get X-rays of other extremities. So the long-term survival does continue to improve. So different diagnoses and prognoses do guide a multidisciplinary management, just meaning that depending on the type of primary tumor that has led to the metastatic bone disease will really guide treatment. And there's a lot more nuance to this, unfortunately, than we can cover right now. But in general, your options are to determine when you see a bone lesion like the one you see on the slide, does this need prophylactic fixation? So the difference between an impending pathologic fracture and an acute pathologic fracture is that that bone on this X-ray here looks like it could fracture, as a lot of the cortices are eroded by the lesion. And so that would be an impending pathologic fracture. Whereas if that bone was actually fractured and displaced or non-displaced, it could be an acute pathologic fracture. So options are internal fixation with postoperative radiation, or you can do a resection, reconstruction of that area. One example of that might be in a proximal femur bone lesion determined to be from kidney cancer. And that might be the only lesion they have outside of the kidney. Because that's oligometastatic, we might more likely do a resection of that area and reconstruction. For example, resect the whole proximal femur and perform a proximal femur replacement. There's other objective criteria that you should know, and I won't go into in depth here, but the Morel and Harrington's criteria, as well as using an online resource called PathFX. Morel's criteria is on the next slide. You should commit that one to memory. Other treatment that you might be a part of is communicating with the medical oncology team and recommending patients to start bisphosphonates or denosumab to improve their overall bone health and decrease their risk of skeletal related events. So here's the Morell's criteria. I won't go over this too much, but do bear in mind that different tumors do behave a little bit differently. For example, breast and prostate lesions, as well as multiple myeloma, are a little more likely to heal, although not in all cases. Breast and prostate can occasionally have what are blastic appearing metastases, so they look like more bones, so osteodense lesions on X-ray. Whereas renal, thyroid, and lung are a little more unlikely to heal. Typically, those are more radiolucent in appearance on X-rays. Renal and thyroid are more likely to require preoperative embolization as they are likely to bleed. And that'll depend on whether or not you're doing an internal fixation or resection, but just something to be aware of as you're working with your team and treating these patients. As far as biopsy and types of resection, so a biopsy is a pretty important concept to know. When to perform a biopsy, again, there's a little bit of nuance for this. A lot of times it's for a bone or soft tissue lesion that is indeterminate on advanced imaging. We don't know exactly what it is, and it's concerning enough that we need to know exactly what it is. So core of the tissue is obtained and sent to the pathologist. We look at it under the microscope, sometimes perform different stains, DNA sequencing, for example, and that'll help us get to a more precise diagnosis. Types of biopsies, they can be closed or open. So a fine needle aspirate or core needle biopsy can be obtained without a trip to the operating room, or if you're in the operating room, a small incision can be made and the tissue obtained through that. Or if it's a superficial soft tissue mass, it's fairly small, you can also just excise the entire mass as part of a marginal excision, and you can look at that under the microscope and determine the pathologic diagnosis. Really, you're only going to want to do that when you know you have an opportunity to go back and resect the whole area in a wide or radical manner if this turned out to be a sarcoma. I won't go through all the biopsy principles, but in general, the biopsy should be performed by the orthopedic oncologist or some member of the multidisciplinary team, or as part of a discussion as a multidisciplinary team to make sure that a future planned surgery is not ruined by the biopsy tract site. So if you're performing a biopsy in the OR, you may, for example, draw out the entire planned incision for the wide resection that's needed if this were to be a bone or soft tissue sarcoma, and then perform the biopsy in line with that incision. So these are usually longitudinal. They go straight through a single compartment, so for example, straight through the muscle. They don't go through neurovascular planes. You avoid the critical neurovascular structures, and you try to get the soft tissue component when that's present. If you're doing this in the OR, you need to obtain strict hemostasis. You don't want to have a large hematoma develop in that area and spread a potentially tumor to a larger area within the soft tissue. And drains are in line with the incision when needed and avoid wide suture margins. So if you're closing up an incisional biopsy site, be sure to keep the stitches pretty close to the incision line. The types of resections are important to know as well. Intralesional, marginal, wide, and radical. Intralesional just means that example, that would be an incisional biopsy, or if you're doing a curettage of a giant cell tumor bone, that's a benign but locally aggressive tumor. And so we typically remove those intralesionally. So we get within the tumor mass itself and then remove it. Marginal is kind of going through the pseudocapsule of the tumor. That could be an excisional biopsy, like I talked about before, or a lipoma. For example, a benign soft tissue tumor that needs to be removed for one reason or another, and you take it out in a marginal fashion. Wide is when you take out a tumor and you never really see the tumor. So you're taking your resection margin is through normal tissue, and the tumor is all contained and surrounded by normal tissue. So for a soft tissue sarcoma, we would go through the surrounding muscle and again, try not to ever see the tumor itself. Radical means excising the entire compartment, like removing the entire posterior thigh. There's an example of a true cut needle, which can be used to perform a cord needle biopsy as well up here. You can familiarize yourself with that using the diagram or again, watch some YouTube videos. As far as most common benign bone and soft tissue tumors, there are many of these. You'll have to kind of read about these as they come up on your rotation, but I do want to touch on, I think, one of the three most common that you might see in clinic and just talk about a general treatment algorithm. So for benign bone tumors, you can have latent, active, and aggressive. For the latent benign bone tumors, you're typically just going to observe these with radiographs at defined intervals until skeletal maturity for children, as these usually stop growing at that point. For active and aggressive, you're going to do close observation, but sometimes a percutaneous or surgical intervention. Again, just giving you very general treatment algorithms. For benign soft tissue masses, or what you think are benign soft tissue masses, if they're less than 5 centimeters, typically observation or marginal excision is preferred, and based on patient preference. And if they're over 5 centimeters or deep, closer observation versus biopsy versus marginal excision before the involvement of critical structures. For example, a large, deep lipomatous mass, or what looks like a lipomatous mass in MRI, may be more closely observed when it's deep to fascia and greater than 5 centimeters. If there's any area of concern that doesn't look like fat, you may also get a biopsy of that area to prove and further know what you're dealing with exactly. There's some great additional reading resources by one of my mentors, Dr. Ballach, which covers soft tissue tumors and bone tumors, basic workup and management. So for the three most common that I think you'll see, I think it's worth knowing these points. So osteochondromas are benign bone and cartilage tumors, typically seen at they can really be seen at any age, but typically they stop growing once skeleton matures. So you're mostly going to see these in patients with open growth plates. They grow away from the joint in the physis. And when you look at them on X-ray here, or even on an MRI, you're going to see corticomedullary continuity. So that means the cortex of the bone is continuous with the bone, with the osteochondroma, and the medulla is as well. So here you can trace the cortex around, and you can see that the medulla of the bone is continuous with the medulla of the osteochondroma. These can be seen in multiple occasions in patients with multiple hereditary exostosis, which is transmitted in an autosomal dominant fashion. So typically, if you're seeing this in a kid, one of the parents, the biological parents, the mother or father, will probably have this and know about it, and they'll tell you. But if you see X-rays where you see multiple osteochondromas, you should be thinking at least about this as part of your diagnosis. Again, these are typically observed until skeletal maturity, or if the cartilage cap is greater than 2 centimeters, marginal excision if symptomatic. For enchondromas, these are benign tumors of cartilage, typically within the medullary cavity of the diaphysis and metaphysis, most common locations being the proximal humerus and the distal femur. Many times you'll be in clinic, you'll see patients present with what looks like an enchondroma, but they were sent by, for instance, a sports medicine physician because they also had some rotator cuff pathology. X-rays during that clinic showed this lesion. The patient didn't know about it. And so sometimes you're getting sent to evaluate and make sure this doesn't look like something more nefarious, such as a chondrosarcoma. Very rarely, an enchondroma can transform into a chondrosarcoma or a malignant tumor of the cartilage cells. You'll see more of these enchondromas in conditions such as OA disease and Maffucci syndrome. The treatment is typically observation. They really only require curettage when present in fingers due to pathologic fracture. What we're looking for is to make sure that there's no significant scalloping of the cortex, erosion of the cortex, or soft tissue component. If these grow quickly on short-term follow-up X-rays, then there may be a concern that this is something more than a simple enchondroma. Most of the times you're seeing patients with simple benign enchondromas. There's a lot more we could talk about central cartilaginous tumors, but that's a little beyond the scope of this talk. As far as lipomas, these are benign tumor of fat. This is isointensive fat on all MRI sequences. These can be subcutaneous, intramuscular, or deep. So here's an example of an intramuscular lipoma. You can see the subcutaneous fat is white on a T1. As we mentioned, T1, the fat is white and lighter than the surrounding skeletal muscle. So this is within the skeletal muscle of the thigh. When they're large and deep, they may be an atypical lipomatous tumor, also called an ALT. That's determined after the resection or biopsy showing MDM2 positivity, and that just increases the risk of local recurrence. But in general, you can just kind of lump these in and call them lipomatous tumors because they are isointense fat on all pulse sequences on MRI. Here's the T2 showing that, again, the fat is isointense to the subcutaneous fat. Typically observation versus marginal excision, as mentioned before. As far as soft tissue sarcomas, the general treatment algorithm, and some specific diagnosis pearls. I'm just going to go through the general treatment algorithm and let you refer to the slides for some of the specifics. So there's at least 50 different subtypes characterized by histology and molecular testing. You can use the term generically to say a soft tissue sarcoma for any soft tissue mass that is malignant. But again, there's a number of specific diagnoses which we'll go through. The general treatment algorithm for a soft tissue sarcoma after it's confirmed with a biopsy is to get systemic staging with a CT chest without contrast, as these most commonly metastasize to the lungs, and then to use either preoperative or postoperative radiation therapy with wide surgical excision. Systemic therapy such as adriamycin, ifosfamide is controversial. There's a small overall survival benefit, but significant side effects. So this is typically going to be discussed with the medical oncology team and the patient in a multidisciplinary fashion. On MRI, when you see soft tissue sarcomas, they're going to be dark on T1, bright on T2, and enhanced with contrast. So burn that in your brain, bright on dark on T1, bright on T2, and enhanced with contrast. So here's an example of dark on T1, bright on T2, and enhancing with contrast. After getting radiation therapy, there may be the tumor may less enhance with contrast, as when the tumors die and kind of bleed into the center, they can actually get a little larger on radiation therapy. But what you'll notice is that the dead tumor cells don't enhance with contrast, and you'll see mostly enhancement around the periphery of the tumor or in different spots throughout the tumor. But typically, before radiation therapy, they're going to be dark on T1, bright on T2, enhance with contrast. There are some soft tissue sarcomas that have lymph node metastases. I like to use the CARES mnemonic. You can read that and commit this to memory. When that's the case, sometimes we'll also add in a PET CT as part of the systemic staging or even a sentinel lymph node biopsy. There's a great review that was published recently on adult soft tissue sarcomas of the extremities, which you can check out here. Again, the general treatment algorithm, though, is going to be a wide surgical excision with pre or post-operative radiation therapy, typically preoperative, with the goal to salvage the limb, decrease the chances of local recurrence, and decrease the need for amputation. Again, I'll leave this just for later reference, but this is just showing an example of a soft tissue sarcoma in its pseudocapsule, showing that typically we use the preoperative radiation to help allow us to get closer on these margins. And then you could potentially have a skip metastases away from the primary site of tumor. So when we do get an MRI as part of the local staging workup, it does involve the entire extremity. So a soft tissue sarcoma in the quadriceps muscle, we would order an MRI with or without contrast of the entire femur. So bone sarcoma, general treatment algorithms, and specific diagnostic pearls. Again, I'm just going to go over the general treatment algorithm. But the bone sarcomas, after a biopsy confirms the diagnosis, the local and systemic staging are going to depend on the diagnosis. And I generally think of this as a workup where you go from less complex to more complex. So chondrosarcoma is a little less complex, osteosarcoma, moderate complexity, Ewing sarcoma, more complex. So in general, you're going to get radiographs of the entire bone and then an MRI with and without contrast of the whole bone. That's your local staging after initial x-rays showed you your likely diagnosis and a biopsy confirmed. Systemic staging is typically going to be a CT chest without contrast, as again, bone sarcoma is most likely metastasized to the lungs. And then a bone scan or an FDG PET CT will show you sites that potentially metastatic sites that didn't metastasize to the lungs, but to other locations. For Ewing sarcoma, it's a little more complicated in that some institutions will get a bilateral iliac crest aspirate and bone marrow biopsy, plus minus a screening of the MRI of the screening MRI of the spine and the pelvis, as Ewing sarcoma has a little more atypical metastases. Chondrosarcoma is essentially a surgical disease. It's treated with wider section with or without reconstruction. There's not typically any adjuvant chemotherapy or radiation therapy that's effective except for some of the different subtypes. For osteosarcoma, the treatment paradigm is going to be chemotherapy, surgery, chemotherapy sandwich. This is the type of chemotherapy that's typically used. And after your preoperative chemotherapy, you're going to restage before your surgery. And for Ewing sarcoma, they're more radiosensitive. So sometimes you can replace the wide surgical resection with radiation therapy for your local control. But this is also going to follow the treatment paradigm of chemotherapy, surgery, and chemotherapy. Just going back a minute, when we do talk about the reconstruction following the wide resection, this typically is going to be attempted with a limb-sparing surgery, meaning the patient keeps their entire limb rather than an amputation. But there also are what we call the 4 A's of reconstruction, which is amputation, which includes a rotationplasty, allograft reconstructions, which may be used for a patient with open physes, and you want to spare their remaining growth if they're very young. And so you can replace the bone that you resected with allograft or donor cadaver bone. And then there's arthrodesis, so fusing the bone together around the joints, and then arthroplasty. So, for example, resecting the entire distal femur and replacing with a distal femur replacement, which is a limb sparing surgery, which allows this patient to continue to bend the knee. This is just an example of an osteosarcoma. Again, two resources for further exploration. This is for your reference later on while on the rotation. So as far as physical exam maneuvers, there's not many unique exam maneuvers in orthopedic oncology. You pretty much just need to do a standard physical exam, focus on the extremity involved. You can continue to keep in mind your three boxes, so bone, soft tissue tumors, and the metastatic disease. The bone tumors are typically going to present either as an incidentally noted lesion, a painless bony mass, a painful bone lesion, or a pathologic fracture, whereas the soft tissue tumors are also present like in a similar manner, either with an incidentally noted but not palpable mass, a palpable mass that is growing or not, and sometimes with a painful mass, whereas metastatic disease is going to present with either pathologic or impending pathologic fracture or a skeletal lesion of unknown significance in the setting of a patient with cancer. The key really here is that you determine if the lesion is actually responsible for the symptoms the patient's experiencing, if they are, and determine the etiology of their pain. Typically, that's going to be you relying on physical exam maneuvers from other rotations that you've learned. For instance, a patient with a proximal humerus enchondroma, well, it looks like an enchondroma on X-ray, presents with shoulder pain. You need to determine if that shoulder pain is actually from rotator cuff pathology or some other intra-articular shoulder pathology. So here's some example of some questions you might ask in clinic for these different conditions. Again, this isn't exactly comprehensive, but it's a list of questions that you could rely on as you start taking histories in these clinics. One thing I will point out is for soft tissue tumors, something you might add to your exam is try to palpate the mass if it's palpable. Try to determine based on palpation whether that's a superficial or deep location, see if it's tender. You can perform a Tinel sign over the mass, meaning if you tap on the mass for some benign nerve sheath tumors, such as schwannoma, you may have a Tinel sign in which the pain will radiate in the distribution of the involved nerve. You can determine if certain masses move or remain fixed to the underlying fascia or tendon. For example, when examining a soft tissue mass in the hand, is it gliding with the tendon as they bend and flex and extend their finger, and determining if soft tissue mass is transluminates. For example, cysts will transluminate with light. Really, what you need to know is that age and location can really narrow your differential diagnosis. And what we'll also go through is how using simple radiographs can really help narrow and determine your differential diagnosis. So this is just one example from the Miller Review written by Dr. Ginger Holt, which you can refer back to. But as you know, and what we discussed is when patients are over the age of 30 or 40 years old, you're starting to think more about metastatic disease, myeloma, lymphoma, sometimes chondrosarcoma, whereas other diseases like osteosarcoma, Ewing sarcoma are a little more common in kids. Chondroblastoma is almost exclusively seen in adolescents and kids, as well as other benign aggressive cysts such as aneurysmal bone cysts. So using Bill Enneking, who's the father of orthopedic oncology's original questions, and also talking about age, and I'll go to a more simple version of the slide next. His questions were, where is the lesion? What is the tumor doing to the bone? What is the bone? How is the bone responding to the tumor? And what is the lesion and any clues to its histology based on what you see on X-ray? So I tried to simplify this into a mnemonic, which I called alarms. So the A being age, which you saw, that can immediately narrow your differential diagnosis. Location, so which bone is involved and which part of the bone. So is this in the diaphysis, the metaphysis, or epiphysis? What's the location with the bone? Is it central, eccentric, intramedullary, extramedullary surface, or cortical? Is it in more than location, unifocal or multifocal? So again, these are all terminologies that you'll be able to use and practice on your orthopedic oncology rotation as you look at X-rays and speak with your attending and other members of the team. These are types of terminology you're going to want to use when they ask you, hey, can you describe that X-ray? So ALA, so activity between the bone and the tumor. What we're really referring to here is the zone of transition. Is it a narrow zone of transmission or is it wide? And what's the margin? So Lodwick had a classification system based on the margin where you have geographic, permeative, and moth-eaten. So for example, geographic, there's three subtypes within that, but essentially geographic just means you can trace your finger around the lesion, and that's a geographic margin. Whereas a moth-eaten and permeative, you can't really trace your finger around the lesion anymore. The the lesion is much more blurred and smudged. So metastatic lesions, for example, are going to be more destructive, moth-eaten, and permeative margins, or something like osteomyelitis or even Ewing sarcoma. So if you see a geographic margin based on the logic classification system, that will point you more towards a benign bone tumor. And again, all of this is really just looking at X-rays for bone tumors. So ALAR, response remodeling reaction. This is periosteal reaction, which has various subtypes, which you can see here. The bone remodeling is the cortex thinning, or is it thickening, or is it expanding, or being eroded? Is there a soft tissue component? And then the M is for matrix or mineralization. So sometimes different bone lesions will form mineral, and this can look like osteoid, which looks like increased osteoid density on the X-rays. Cartilaginous matrix looks like these arcs and rings or stippled arcs and rings, popcorn calcifications, typically within the intramedullary space of the bone. And then fibrous, which is like a smudged appearance of the bone or ground glass, almost like if you took a piece of plexiglass and tried to look through it. This is kind of the same appearance that we think of for fibrous. Osteocartilaginous and fibrous are your different types of matrix. And then finally, size. So that's the alarms mnemonic for looking at X-rays of the bone to help narrow your differential diagnosis within clinic. One other comment I'll make on the zone of transition within this activity section is that this really tells you the biologic activity and growth rate of the tumor. So you can think about a narrow zone of transition means slower growth. Again, you can trace your finger around it. It's a narrow zone of transition. And so you can almost think of it like the body has had time to respond to the tumor. So if you see a sclerotic rim around the tumor, the body has had time to lay down that bone and surround and wall off the tumor. Whereas if you see a wide zone of transition, that's more indicative of a increased biologic activity, increased growth rate. You can't trace your finger around it anymore. And so you can basically think of it like the body is not able to respond fast enough to the tumor. And so you have this wide zone of transition. Again, this doesn't necessarily determine whether something's benign or malignant, but it can suggest, just like an increasing aggressiveness of a periosteal reaction, can be more and more suggestive of increased biologic activity. Okay, so now we're in the part of the talk focusing less on factoids and what you can do specifically for this subspecialty irritation. There's a lot of text listed on these slides, so you can use these slides independent of this video for review. For time, I won't talk through all of it. This is also largely my personal opinions and observations of working with students for the past several years. However, many of these ideas I source from mentors and friends, as well as other current medical students. Remember, I said there's a lot of OR and case variability in orthopedic oncology. Know that some cases like pelvic resections, working on critical neurovascular structures, and placing large metal implants can be stressful, with a very high rate of complications, especially infection, wound healing problems in this field. So if you're much less involved in these cases, don't take it personally. They're just more stressful for the surgeon, and there are many moving parts and little steps that ultimately lead to a greater outcome for the patient. In general, for big cases, err on the side of being a little less involved and a little less gung-ho. Be prepared, but wait until you're asked to do something. For example, if the team is prepping and draping for a large metal megaprosthesis case, especially a young patient who's immunosuppressed from preoperative chemotherapy, remember that the infection risk is really high and the sterility is paramount. And one of the only things that we can control as surgeons. So if you're not getting involved in that part, or they take over holding the limb, or take over one of the drapes, don't be offended. It's just us being a little even extra careful with the sterility. The more you're prepared and know the surrounding anatomy, the better an assistant you can be. For example, be careful not to tug or pull on nerves, as careful minimization of traction on nerves can optimize postoperative outcome and function. Be gentle whenever you're manipulating these limbs. These patients are often frail, whether it's a bone sarcoma, soft tissue sarcoma, or metastatic disease, all three of the boxes we talked about. For example, in an impending pathologic fracture of the femur, that could complete and become displaced with manipulation of the limb before surgery, and that could really complicate the surgery and change what exactly has to be done and make it more complicated. Always ask before manipulating limb, and if you do, always use two hands and move the entire bone as one unit. So how can you shine in the OR? Again, in big cases, there's many moving parts, and you can be helpful and assistant in the case. Again, the more prepared you are for the case anatomy and you know the surrounding neurovascular structures at risk and you know the steps of the case, the better an assistant you can be. And that really shines through when you're able to show how prepared you are by being such a good assistant. There's also some distinct skills that you may have a chance to demonstrate and can practice. For example, hand tying. In orthopedic oncology, we're often obtaining hemostasis from a number of ways, but many times this involves tying a hand tie. So make sure before you get to the OR, you practice your one hand ties as well as your two hand ties. Be careful that when you're practicing these, that you really emphasize pushing down with your index finger on the knots as this can make a difference when we're working in a deep, dark hole. A lot of times at the end of these cases, there's a large incision that has to get closed, and a lot of times we use something on the skin like interrupted nylon sutures. So we really do try to value your time, and if you've stuck it out through a long 3 or 6 hour case, most people will try to get you involved and throw in some of those skin stitches at the end. Drains are often used, and some people will use a drain stitch. This can be an opportunity for you also to practice throwing a drain stitch. So look up some YouTube videos on that if you've never done that before, or pay attention on other services where people are putting in drain stitches. Usually, the general surgery or plastic surgery teams do that more often. Occasionally, if you're with an attending alone or um, based on just the hands that are available in the case, a lot of dissection for soft tissue sarcomas will involve using some type of dissecting tool, like a right angle or a Schnitt. And often the tissue will be elevated up, and the bovie will be used to coagulate the tissue on top of the dissecting clamp. Occasionally, you'll get a chance to do this. Usually, you're going to use the coag button. You can double check with the attending. And the key thing here is really not to pass point, meaning whatever tissue they've elevated, you want to just burn that tissue and not go any deeper, because right beneath that, that layer may be something critical like an artery, vein, or nerve. Sometimes you'll have to learn the different instruments that are used, as in orthopedic oncology, we occasionally use instruments that are a little bit different from the rest of your orthopedic rotations. For example, we'll use vessel clips, as you can see up here in the top right, or a ligature on the far right. This is an example of a typical dissecting tool, Metzenbaum scissors, and a DeBakey for obtaining meticulous hemostasis. If you are involved in some of the hemostasis that's being obtained, a standard method for tying off a vein or an artery might be to pass two sutures, typically like a 2O or O silk stitch. Those will each get tied. So tie, tie, cut, cut, cut. So after those two are tied, you may be handed the Metzenbaum scissors. You'll cut between the ties, which will separate the vessel, and then you'll cut the two sutures with a short tail, usually about a centimeter, and that'll continue. That'll complete the coagulation of that vessel. And then, as I mentioned, you'll see many techniques for obtaining hemostasis in different instruments. Just pay attention to the different ways that different surgeons are getting hemostasis, as this can help you not just with a future career in orthopedic oncology, but really in any area of surgery you end up in. It's a good opportunity for learning. I won't talk too much about this, but I do think these two articles that are starred are probably the most bang for your buck, as they cover imaging. And I think your ability to learn imaging of orthopedic oncology conditions is going to be really helpful to you, no matter, again, what you go into. But it can really help you shine on the rotation if you are asked to describe an X-ray or an MRI and you know some of the main facts. So I think these two papers starred are really great, one for MRI and one for X-ray analysis of bone lesions. And then finally, there's a number of learning resources here listed. This is many resources that I try to give for the residents who are on the rotation for a longer period of time. Some of these other ones outside of the starred bullet points may be more useful if you're doing a full 4 weeks, for example, on an orthopedic oncology rotation, but most of these books are a little too expensive to actually buy for a short rotation. So if you're on a short short rotation, the BOSTT app is free. You can use that to look at example cases and also search by diagnosis for a quick lookup of something you've never heard of in clinic, maybe a little more reliable than a Google or PubMed search. And then Dr. Wittig has a free book on his website, tumorsurgery.org. If you just Google tumorsurgery.org and then whatever case you're preparing for, you might find one of the older versions of a book that he wrote. And that can be a good starting point. For example, if you Googled proximal tibia replacement, you could find a chapter on doing proximal tibia replacement. And that's all free. Final words of wisdom. If you prep for clinic at least the night before, you can really read specifically about some of the conditions you'll see. Otherwise, it can be a bit overwhelming just because there's a lot of variety in what we see and treat. You can then focus some readings with some of the resources I mentioned, or even quick ortho bullets pages. Recognize also in clinic that if you're seeing new patients, you're going to require a lot more time. You're going to need a longer note and history taking than a return patient. Oftentimes, the attending won't know everything about these new patients. They may have gotten an email about them or communicated with other members of the team, but you can really shine by getting a detailed history covering the salient points for that orthopedic oncology new patient. If it's a return visit or a post-operative visit, you don't always have to spend as much time for the sake of the efficiency of the clinic. The attending property knows these patients, and you're just going in there and getting a focused history and really just reminding the attending during your presentation. As always, never forget to practice empathy. It's important everywhere, but it's especially important in the orthopedic oncology clinic. You need to be caring and you need to be tactful. As some of these patients, you're really seeing them on probably the worst day of their life. And you can continue greatly to contribute greatly to the team with your fresh medical knowledge and your own unique perspective. A lot of times you're closer to some of the things that we don't always think about after the farther you get in training and the more specialized. So you can really be a critical and vital part of the team. So don't forget that the attending also benefits a lot from having you in clinic, working with them and providing a fresh perspective. Okay, so now we'll do the quick quiz. This is basically just five quick questions that you may hear come up while you're on the rotation. So what is your differential diagnosis for a patient over the age of 40 years old with a new radiolucent or lytic bone lesion with moth-eaten or permanent borders? Yeah, so remember, metastatic disease is going to be the most common. So we say Mets, myeloma, lymphoma. You can also throw chondrosarcoma in there as a possible primary bone tumor, as these are more common in older adult patients. Question two, where are soft tissue sarcomas most likely to metastasize? So as we talked about, the soft tissue sarcomas are most likely to metastasize to the lungs. So we get a CT chest without contrast as a typical imaging modality for systemic staging. Some patients will also benefit from an FDG PET CT as well. It's institution dependent and based on specific histopathologic diagnosis dependent as well. For instance, some kids who have a suspected osteosarcoma, which is then biopsy improved as an osteosarcoma, will get a CT test without contrast, followed up by an FDG PET CT. The dedicated CT scan of the chest is more accurate than the CT portion of the PET. There's a little better resolution for sub-centimeter nodules and a little better sensitivity for that. So we don't usually like to just do the PET CT. But the PET CT does have the benefit of showing you areas of increased uptake, hypermetabolic activity, basically from head to toe. So look for other sites of metastatic disease outside of just the lungs. Question three, what is the general treatment algorithm for an adolescent patient with a new diagnosis of a distal femur osteosarcoma that was then confirmed on a biopsy? The MRI of the femur shows no skip lesion. So you're dealing with a localized osteosarcoma in the distal femur. So this is where we talk about essentially the chemotherapy, surgery, chemotherapy sandwich. So neoadjuvant chemotherapy or preoperative chemotherapy, followed by a wide surgical resection with reconstruction. Limb salvage is the standard of care. So typically we would resect the distal femur, perform a distal femur replacement with a number of different types of fixation that can be achieved to accomplish that goal. Question four, what is the general treatment pathway for a 40-year-old woman with an undifferentiated pleomorphic sarcoma, UPS, of the posterior thigh without involvement of the sciatic nerve? The CT chest shows no lung nodules. Again, this is just touching on the general treatment paradigm for a soft tissue sarcoma. So we typically are going to get preoperative radiation therapy, also called neoadjuvant radiation therapy. Plus minus systemic therapy, it's still pretty controversial, and it's going to be a case by case on whether or not these patients are going to get some type of systemic therapy, followed by a limb sparing wide surgical resection of the mass, in which we'll try to save the sciatic nerve. So remember that the preoperative radiation therapy helps us be a little closer with our margins and thus perform a better limb sparing or limb salvage approach by being able to save the sciatic nerve. And you could also, the correct answer to this could also be to perform a wide surgical resection followed by postoperative radiation therapy. And just try to keep in mind the different pros and cons of doing preoperative versus postoperative radiation therapy. But remember that for a soft tissue sarcoma, the general treatment algorithm is going to be radiation plus wide surgical resection. Question five, what carcinomas most commonly metastasize to bone? Right, so this is the BLTKPs, breast, lung, thyroid, kidney, and prostate. And remember that the kidney and lung lesions are a little more likely to progress, whereas breast and prostate may be better treated with systemic therapy. Remember that thyroid and kidney typically need to get an embolization because they have a propensity to bleed more. So you'll get a preoperative embolization of the tumor. And again, these are just general statements about these, but good to know at your level of training. So thank you guys for listening. Again, if you have any questions about these slides or any suggestions, please shoot me an email. Thanks.